Okay, thanks, guys. All the non-spine surgeons can leave now. Okay, so now we love trauma at Jefferson. Steve was there, Matt was there. It's the largest spinal cord injury center in the country. Things come in left and right. When I was a resident, Kotler, my boss, who was great, would allow me to fly in fixed wing aircraft to go out. Like I'd go to the Virgin Islands to pick up spinal cord injury. I go to Vegas and I tell the pilot, give me 6 hours to hang out and then the plane could take off. So I loved it. So it's big. And as a result of its size, we wrote a lot of papers. And I remember when I first got there in the 90s, the big thing was gang warfare. So we wrote a bunch of papers on gunshot wounds to the spine. And the little trick that the gangs would use, and they're doing it again, is they'd shoot somebody and they'd wait for the ambulance to come up. And then they'd shoot them again in the upper brainstem to make the patient be locked in so they could only move their eyes. And that was a message. They're doing it again in Philadelphia again. Because people are coming in with spinal injuries from gunshot. I'm like, that guy's a pretty good shot. I'm like, wow, that thing went right there. It's because they wait until the ambulance gets there and then they shoot them in the spinal cord because they want the person to be miserable and horrible. So we wrote a lot of papers. So as part of the Jefferson system, and so the big thing now in our spinal cord injury centers, you want fresh trauma. You want the people at the beach that, head plant, body surfing. Don't ever do that, by the way. The New Jersey beaches are horrible because they have a steep incline, they're barrier islands. It's not like the Caribbean. Do not body surf at the beach on a bad day because your head will go right into the sand and you'll be a flexion distraction. We get like 12 a year from the Jersey beach. It's like it produces spinal cord injury, so you don't want to do that. There's certain things you don't want to do. Ride drunk on an ATV, shoot a gun in a deer stand drunk. These are my patient population. Joy riding and drag racing in the city, bad idea. And swimming like that. And the other thing you want to do, which I almost did, is I went pool hopping. When I was in high school, that was a favorite hop. Who went pool hopping? So we would go every night to like 4 or 5 different pools. And I remember my friend Tommy Tavaroni, everyone was Italian when I grew up, was about to jump off this fence into a pool. And I go, Tommy, wait a second. I don't think there's any water in that pool. He's like, what are you talking? And he was about to do a dive. So I pick up a rock and I thought, clank, clank. I go, dude, you could have died. I had patients like that come in who dove into pools at night with no water in. And I go, what happened? He goes, there was no water in the pool. So pool hopping, if you guys want to do it as residents, be careful. See, these are the things. So you got to watch out. Now, the spinal cord injury population has changed. Let me tell you, what type of patient with a spinal neurologic deficit do you think I see 3 to 4 times a week at Jefferson now? I'm not going to tell you what they have, but what type of patient with a neurologic deficit 3 to 4 times a week do we see at Jefferson now? Okay, now we see spinal infections now. That's every system in Southeast Pennsylvania sends the IV drug abusers, and they don't have to be IV drug abusers. They could be elderly immunocompromised. We see a lot of, and we see central cords. So the old days of burst fractures, thoracolumbar spine, flexion distraction, dislocations, now we're seeing neurologic deficits from IV drug abusers. It's all over the place, 3 or 4 times a week, odontoid fractures and central cords. So that's what we end up writing about. Now, the things that interest me is when the family says, will he walk again? I'd like to be God, and I'd like to know the answer, and I don't know the answer. So the only 3 things I know about trauma is the faster you take the pressure off the spinal cord, the better, if you want to walk again. The faster you stabilize the spine, the better. And everything else that we do doesn't work. Steroids, all the other things doesn't work. And the last is get the blood pressure up. So if you know nothing and you're on call as a foot and ankle surgeon, and you get a phone call before you can find the spine surgeon, say, get the blood pressure up, get the operating room ready, and then get the spine surgeon to take the pressure off and stabilize. Because most of the studies have shown that makes sense. So Wilson, the previous slide, was one of our fellows that worked on all these AI systems to figure out, can you prognosticate outcome at a year by the findings on the MRI scan? And this paper basically measured the injury distance, less than 4.5 centimeters. Those patients can walk. So I have so many anecdotal stories of Asia A's that come in that I operated on within an hour that have walked. I don't have any anecdotal stories of Asia A's that we let wait a week or so that walked, assuming they were really in Asia A. So I like to be able to prognosticate that makes sense. Now, Adam Flanders, do you remember Adam Flanders from radiology? So he's doing all these cool MRI techniques that we haven't put into practice. We can take a look at the fibers of the spinal cord. We could look at the connectivity. We could do functional MRIs. Have you guys ever seen a patient with a conversion disorder who is not moving their legs, but there's nothing wrong, and you literally take a pin and stick it through the toe, and they look at you like, I don't feel that. And then all of a sudden, when you give them psych meds, they get up and walk out of the hospital. Have you seen that before? Yeah, I've seen that before. And I'm watching the resident torture the patient, and the guy's not blinking. And then all of a sudden, they see the psychiatry department. So functional MRIs can look at that portion of the brain, and they can figure it out. So these are all the little things that we're doing at Jefferson to experiment. It's really cool. So we get pictures like this of the spinal cord. So you can literally see the tracks. What percentage of tracks have to be intact for you to have the potential to move your lower extremities? You know what the number is? Only 6 to 7%. I've seen some really bad spinal cord injuries where cavitated 6 to 7%. So this type of tactography allows us to see inside. And then what we're doing at Jefferson is sampling the spinal fluid. So we're going in and taking CSF markers, and it doesn't tell us how to treat the patient, because again, we only have 3 tools: operate early, stabilize, get the blood pressure up. That's only 3 tools we have. That's this entire talk. But we can take samples and look at it, and we can say, oh, that cytokine, that biomarker is increased. That person's not going to do well. And then we can look at the potential to convert your Asia injury score, A, B, C, or D, or your motor score. And I always say you need to get 5 to 6 points in a motor score to really have a significant improvement in someone's life. Like if you're C5, it stinks. You want to be a C6. The C6, you can extend your wrist. I can put a cock-up splint on so you can grasp something. People want to be able to grab things. I want people to be a C7, C8. So I know the earlier I operate, I can get quicker conversion on a single level nerve repair. So I'm a very aggressive spinal cord injury surgeon. I go in pretty quickly. And then there's these messengers, these short non-coding RNAs that are produced after the trauma, and they help us understand that person has the potential to get better over time. These are the things that allow the genome to be expressed. So these are the things we're doing in the laboratory that are really cool, that have not moved the needle, but they have helped us to prognosticate. So I just think that's cool. Now, MAPs. I'm really nervous now that the Miami Center has published their seminal paper on decreasing core temperature. I don't know if anyone saw that paper. So they had a bunch of paper, it's like what they did to that guy with central cord in Buffalo. That's going to be a pain in the ass, because in the Eagles locker room, they made us refrigerate 3 liters of cooled normal saline. I'm like, that's not what dropping a core temperature is. You had to put a central line in, you got to put them in the ICU and stuff like that. They said, okay, if someone has a spinal cord injury, we want to give all this fluid. So in the locker room before an Eagles game and at halftime, we always give fluids to the patients. You give them IV Toradol, you give them stuff, and that's what the doctors do all day. And then you watch the air embolus go into their arm and go, oh my God, I hope he doesn't have a stroke out there. That happens to me a lot. I'm like, is it good for that air to go into the arm? So, the trainers know how to do it. I just sit there and I just open it up and stuff like that. But they wanted us to do that. But a paper came out that said dropping core temperature may be effective, which is a problem. Maintaining mean arterial pressure is a nightmare. If anyone's been at Jefferson, you tell the ICU team, keep the mean at 85. And then if you actually look at it, it's like at 30, 29, 8, 120, and it's all over the place. So I always say, I hope it doesn't become the standard of care, because it's hard to maintain pressure. So we did systematic reviews. There's nothing in the literature that says what to do. So we did a few studies that said, okay, if someone has high blood pressure, they don't tend to perfuse the cords. You have to give them more blood pressure. So here's the bottom line. You're operating on a central cord patient, spinal cord injury patient. You're in the operating room, you have a neurologic deficit. Minimum of 3 days to 5 days, keep the blood pressure up. It's hard to go beyond 3 days. The ICU loses interest. It just doesn't happen. Who's managing you're not managing the pressors. So try to keep the blood pressure up. Anytime I do a reduction of a deformity in the operating room, when I'm operating on severe myelopathy, I always say, A-line, keep the pressure 85. Sometimes the anesthesiologist gets lazy. Hey, can I use a cuff pressure? How comfortable are you with the cuff pressure? You think it correlates? Okay, I'm okay with it, because it really slows down my operating room, putting that A-line in. So that's what we have to do. Now, the different societies out there have come out with different regulations. So we're doing a study now at Temple University called the mean arterial blood pressure treatment for acute spinal cord injury. So we're looking at a common sense thing. Does it really matter in spinal cord injury? Can you keep it at 65 or do you have to go to 85? It'll probably be 85. How many people who do spine surgery try to go to 85 when you're doing a myelopathy case? Yeah, I mean, that's what I do. We do that. So that's the bottom line. Now, we have participated in every medicinal study and we participated in the stem cell studies, and none of them have worked. There's one out there that probably doesn't work that you'll see publications that it does work. I just think they're getting a little bit liberal in interpreting the data, and that's really is all in the risk study. And I'll get into that. But we participate in every one of those things. People say to me all the time, do you give steroids? And I do. And then you say, why do you give steroids? And I go, because I've been sued for not giving steroids, even though the literature doesn't support it. So just to avoid getting sued and being miserable and getting deposed, I give steroids. I don't know if it works or not. I kind of feel comfortable giving it. I don't give it for more than 24 hours, but I give it. Matt, do you give it? Yeah, situational. Yeah, I always default to do everything you can. That's not stupid, because people become really irrational when they have a spinal cord, and their families become irrational. So the only thing I know is Phalanx came out after break-in and Hurlburt and everyone, neurosurgeons trashed it. Phalanx came out and said it may be effective for cervical spinal injury. So the AO came out with a position statement that said it's an option. I just give it. I just remove that variable. I represented a doctor at Penn who gave it at 8 hours and 10 minutes. And they said, if you gave it 10 minutes earlier, it would have made a difference. I had to go to court for that guy. That's how stupid the whole legal system is. So that's one of the areas that I can't tell if it works or not. I just give it. Yes, I would get it. Yeah, I would get it. I have no problems with it. Really? Yeah, old, frail, high cord, can't get off a vent. I probably wouldn't give it. I mean, it's situational. Really is all. Was that someone say something? Gotcha. Yeah, stand behind it. Yeah. Yeah. So really is all sodium channel blocker. I participated in the myelopathy study. The only thing that study showed was it decreased neck pain, so it doesn't really make any sense. Now, this paper, it's interesting because I usually don't believe any papers I read, because every pilot study shows that everything cures cancer. So it always cures cancer. And then when they do the stage 3 study, it doesn't work. So this is with A through C, and this is with C. So it looks startling that it may take a C and increase the ability to move your legs. I'm not sure. It's going to be published. It's going to say something positive. It's out there already. It's FDA approved for ALS. It probably doesn't work, but we did this at Jefferson. This is the data so far. So it's interesting. Neuroregeneration, we participated in every stem cell study. It's not approved. I've seen horrible things. So what do stem cells do? They probably don't survive. If they do survive, they're immunosuppressive, anti-inflammatory. There's only 3 things you want to do with a spinal cord injury. You want to get the neurons to sprout. So what can you do to get them to sprout? You want to decrease the scar tissue, and you don't want the myelin to interfere with the regeneration. So the future will be some sort of scaffolding that we transplant in, something to stimulate neuronal growth, where they can find the ends they have to meet with, and you have to decrease scarring. That's what the future is, and then stability. So we really haven't found the cocktail, and everyone is looking at all the different things out there. So I just say, again, the 3 things that I know to do as a surgeon is operate early, stabilize the spine, get the blood pressure up. Classification systems, we've tortured this to death. We've come up with, this was the original, the SLIC system. It's just common sense. What do you see on the x-ray? What do the ligamentous complex looks like? And what's the neurologic status? And then you just give the level of the injury, the morphology, the osseous injury, is there a disc hernia, all that stuff. We did that. And then the AO is the A, B, and C system. So we worked on the AO system. And I sort of like it because it allowed us to get more granular. We have insignificant compression fractures, cleft fractures or pincer fractures, burst single end plate, burst 2 end plates. And this sort of categorizes all the injuries. Then you have the distraction injuries, distractions through bone, just distraction through bone and soft tissue, or distraction extension in metabolic bone disease, and then anything translational. So this is the easiest system to memorize as a resident if you want to communicate. And the thing I like about the system, and it looks at the facet joints, like like, in my opinion, if you make the mistake of coming into my hospital with an odontoid fracture, you're getting surgery. 100%. I'll be blind to everything else. I'm operating. I am, because I think they do great. I don't put you in a collar. I don't take a bone graft. I take a bone cutter. I do a reverse cut on the spinous process. I split into two, like a Bowman graft on both sides. I suture it in, and I'm like, no collar. Send the patient home the next day. Because all the studies show that odontoid fracture, and most people don't operate on it. If you have a facet fracture, I'm also extremely aggressive because I've seen these displace. So this system allows us to look at a stable fracture, less than 40% facet, less than 1 centimeter height. It looks at the lateral mass fracture, that's an ipsilateral, pedicle ipsilateral lamina fracture, and then it looks at pathologic subluxation and so forth. So you just have to memorize it. And then the neurologic classification I love, because a lot of these patients come in, I can't examine them, and that changes your treatment. Someone comes in with a horrible looking MRI and they can't be examined. You're going to wait around 2 days for them to wake up? I don't. I move in right away. So this system has a point system where, how about if they had transient paresis in the field and they see you and the CAT scan looks normal? Guess what? The CAT scan is not normal. There was some sort of pathologic subluxation that's reduced itself. I can't tell you how many lawsuits I've been asked to comment on when the CAT scan is normal and the patient slips 6 days later and becomes quadriplegic. And I defend that doctor. So that's important to know, that the patient had a transient neurologic deficit. And then the modifiers are common sense. Is there a vertebral artery injury? Could the posterior ligamentous complex be disrupted? Is there a critical disc herniation? We need to know that stuff because, again, it can affect treatment. So I'm going to take you guys through very slowly. It's very simple. This system, you just note A, compression, B, distraction, but there's still a tethering, and C, translation. And then the parentheses are more if there's another fracture associated. So it says C, that means translation. A2, it just means that there's a pincer fracture. Remember, A1 is a compression fracture. A2 is a pincer fracture. So we have translation, obviously. Then we have a pincer fracture, A2. So if the resident calls you, I have a C56C, C5A2. Now, A4, I know that's a burst fracture. And remember, A3 is a single end plate, A4 is a 2 end plate, and there's no significant translation. C7T1, okay, we've got something causing translation here. And then F4, I know what that is. F4 is a facet fracture dislocation. And then T1 is a compression fracture. So it's a very simple system. You just have to, it makes you describe exactly what you see. B3, stiffening bone disease, distraction extension. So very simple on what you see. And that's how the system goes. So C56C, translation bad, and then again describes, and you always do the right side first. We have a facet fracture dislocation, and then we have an unstable facet fracture, F2. So you put it all together and it makes sense. Now, the average spine surgeon will treat minimally displaced superior and inferior articular process fractures non-operatively. That's what around the country. I'm very aggressive because I've treated non-operatively and I've had them sublux and I've had them come back with shoulder and arm pain and they get very angry. So I'm like, it's probably going to slip. If you never want to have a headache, you go posteriorly unless you have an F3, which is a lateral mass fracture. Then you have to, if you go posteriorly, you got to do 2 levels because you have a disconnect between the posterior elements and the anterior elements, which if you're not a spine surgeon, don't try to visualize that in your head right now. But I just fix these. And this is the latest paper that says, they do pretty good. 80% of them do great. But remember, 20% don't do great. So what do I like to do? When you have a 70% non-follow-up rate in your clinic, I just fix them. I just come in. I don't know. So most people aren't that aggressive, but I think the literature supports it. And I use the Lee classification where it's if I have greater than a centimeter between the fracture tip and the fracture line or greater than 40%, that's what I use. But if I see subluxation, I get great. Well, I've gone anteriorly on unilaterals before, and I've had them like translate a little bit sometimes. So if you want to hit a home run, you go posteriorly, you'll never lose. But they have more neck pain. I like going anteriorly best, but I've had them. So you got to look at it. if there's a little bit of buttressing, go anteriorly. If there's no buttressing, it's probably safer, just if you don't want to be embarrassed. Because remember, when you fix these anteriorly and they come in, and you were aggressive to begin with, and all of a sudden now you see him subluxing a little bit, you go, ooh, hope he doesn't look at his x-ray. And I usually write a note that says, this person can't be x-rayed for the rest of their lives. It's like a medical card they carry around with them. Now, I can't tell you how many papers we've written about odontoid fractures. You either believe or you don't believe. Most guys in private practice, I'm not going to treat them. I fix everybody. And I always say, and I fight with the neurosurgeons all the time, because the neurosurgeon is very conservative. And like, I'm best friends with all of them, like Ash Sharon. I'm treating that non-operatively. I go, Ash, that patient's going to fall again off their wheelchair next week. And the nursing home's going to get an x-ray. They're going to put the patient on a helicopter again. And they're going to fly in at 2 o'clock. We've had patients come 3 or 4 times to Jefferson by helicopter with an odontoid fracture. I'm like, put 2 screws in the back of the neck, please. Put them in a soft collar. When they get an x-ray, things will look okay. So I fix them all. Now, if you look at registry data, they don't do well after 85 because now they're old and they have comorbidities. So if you look at the Scandinavian countries, they have a lower mortality and lower complication rate up until 85, and then don't do it anymore. And then people say, well, what about a demented patient? I go, demented people fall too. Demented people get x-rays too. Just fix the fracture. You're fixing the fracture. So, and then the other thing I hate is when they come into the office with a family member. When you see the family members waiting outside the room, that means they haven't taken the collar out and it's caused a decubiti that smells. So when you see the family like waiting outside the room like this, and I'm like, oh, am I late? No, just the smell in the room is bad because they don't know what to do with the collar. It's a fracture and they get these horrible decubiti. So fix the fracture and don't put them in a collar afterwards. Now, this is the best slide. So I belong to all these international study groups. If you make the mistake of getting a fracture in Germany, you're going to have an anterior posterior surgery. And I'm talking about a compression fracture. Like on all the study groups I'm on, I'm like, huh? So Scandinavians will not operate. Canadians will not operate. Americans, sometimes not. So everything's cultural. Different cultures are aggressive and different cultures are not aggressive. Keep that in the back of your mind. So it's difficult to get consensus internationally. And I'm sure it has to do with reimbursement and so forth. If they don't pay for you to do anything, you're probably going to be conservative. They pay to do surgery. Germany has a great healthcare system. The other thing that's so confusing is vertebral artery injuries. Now, I'm going to tell you a story about why I publish a lot of papers and I just know the reviewers. I know how they're going to respond to my papers. So I hated JBJS. JBJS hates spine surgery. So there's not many, it's a joint journal. They hate us. So I remember when we first invented MRA in 1993, all of a sudden we're seeing vertebral artery injuries. I'm like, oh, this is bad. So at Jefferson, well, give him heparin right away. Then all of a sudden, the neck would blow up. Then we can't do spine surgery. Okay, don't give heparin. Let's operate first and then give heparin. Okay, let's not do that anymore. Let's operate and let's not do anything. And then they did it. They did okay. So I write it up and I get the typical JBJS review going, I've been a spine surgeon for 30 years and I've never seen this injury before. And I'm like, because we didn't have MRA. We're not doing angiography on these cases. So then Frank Giacobetti and I did a prospective study. We had a 19% vertebral artery injury. So now, if you look at the general surgical literature, they're like, oh, that's bad. Vertebral artery is bad. Stroke, bad. So that's a stroke percentage. And then you have the different classification systems. You have the Bilsel classification. You have the Denver interpretation. And I'm going to go over what we do at Jefferson. So this tells you the stroke rate. This graph talks about let's click up here. 1, abnormality less than 25%, abnormality more than 25%, pseudoaneurysm, bad, occlusion, bad, tract section. I've never seen that before. I've never seen someone come in with a big hematoma from trauma, but they're bad, right? So keep that in mind, 1, 2, and 3. We see 1s and 2s all the time. So now, who should get an MRA? Well, I can look at a T2 weighted image on an MRI and tell you if the vertebral artery is dead. I don't even need anything. I mean, I always laugh when they say, you got to get an MRI. I go, no, I look at a T2 weighted image. I can see vertebral flow. Every time I do an anterior cervical decompression and fusion, I tell the residents, follow the vertebral artery and don't make the mistake of boving into an aberrant vertebral artery across your surgical field, which I've done. Do not make my mistakes. Know exactly what that vertebral artery is at all times. You can see it on a T2 weighted image. And this is who should get it. The people that should get it are the people that have a translational injury, fracture through the foramen, an upper cervical spine injury, I've seen it, or anyone with a neurologic deficit should get it. But I could see it anyway, so it doesn't really matter. And then the treatment guidelines, there's really no good studies. The general surgeons want to heparinize, they want to do all that stuff. It doesn't make any sense to me. So grade 1 and 2, everyone at Jefferson gets aspirin for 30 days. 1 and 2. 325. 981, 325. Everyone gets it. And then a week after, the neurosurgeons or the radiologists will do angiography to see if it's progressive a week later. Now, I've seen occlusion. So we sort of throw, it says heparin, no bolus, level 3. We give them, we don't treat them like the guidelines. And it's interesting, if you look at the guidelines, this is the East guidelines. Surgery or stenting for grade 3. That's a pseudoaneurysm. I leave it up to the neurosurgeons what they want to do. Of course, if there's early neurologic deficit, I'm much more aggressive. And then they want you to do a follow-up angiography. So that's the only thing we do at Jefferson. Grade 1, grade 2, grade 4 occlusion. I don't remember how many pseudoaneurysms I've seen. I'd let the neurosurgeons decide, but everyone gets aspirin, everyone gets a follow-up angiography. That's all I would do. You're safe if you do that. That's like the biggest controversy now. And then the Western Trauma Association has these complicated guidelines that I defer to. Now, timing of surgery, be aggressive. And this is a total anecdote. This is a bad paper that we wrote. It's like seminal paper. It's just a bad paper because it's a prospective cohort of people who are aggressive. Early surgery was averaging 14.4 hours, late was 48 hours. But I'm a big advocate of taking pressure off the spinal cord. If you have an ASIA A and you have a translational abnormality. And we started with 470, and what we showed, it's 14 hours for early, 48 for late. We showed that the more advanced groups, this is early, this is red, had a higher conversion in terms of AIS scores. And if you had a high grade impairment, you were more likely to do better if you had early surgery. So that sort of got people to be more motivated. And when we did a regression analysis, we looked at the presenting ASIA score correlates, of course, with the terminal ASIA score, but age didn't make anything, comorbidities didn't make anything, giving steroids didn't have anything, but the timing of surgery did. So the only thing that confuses me at this paper, it's a 6-month follow-up. And I always say to myself, why didn't they do a long-term follow-up? And you know why I think they didn't do a long-term follow-up? Because maybe it doesn't show anything. I don't have the data for this. I was just the guy who wrote the paper, but I always say, well, we should write a long-term follow-up. And the data's there. So I always ask the lead surgeon. Now, central cord injuries, the data's clear. Again, if you're in private practice, if you're not really into it, you're going to put them in a collar. The data's clear, early surgery is better for medical comorbidities and neurologic return. And we just published a paper. Does anyone know where we just published a paper last week? Does anyone look at the literature where we published a paper last week? In JAMA. Steve, JAMA last week on central cord, operate early. They do better. I'm a big advocate of operating early, unless they say no. Family says, no, I don't do it. So operate early, keep the blood pressure up. We're doing this study now. There's my brother, one of my brother's best friends, very successful private equity guy. And both my brothers work for private equity. And he was coming home late from New York City, and he was lying in the back of his limousine. Guy got into an accident. The limousine company had no insurance. He became a paraplegic. He came to see Bob Heery. Bob Heery fixed him. And he's a crazy guy. And he's giving us a ton of money to do this type of surgery. So what we're doing is we're using closed loop, single channel implantables to get people to walk again. And this guy has unlimited money. So we're really experimenting on it now, where just thoughts to get the extremities moving, get it early when you still have the joints and stuff like that. So that's what we're working on at Jefferson. And the guy's great. The last thing we did is that we have outcome measures for everything, but we don't have outcome measures for spinal trauma. So in one of our study groups, we sat down, we came up with a physician-reported outcome, and we have a patient-reported outcome where we, patient and then surgeon, and we're doing that now. So what I did is I sort of ran through all the top issues that we have in spinal trauma now. Again, let me just conclude. My one word to conclude the private equity talk was greed. And my 3 words for spinal trauma is operate early, stabilize early, and get the blood pressure up. Everything else hasn't really moved the needle. Thank you. So, any questions? Yes, Rich. No. You can't. So I'm going to tell you how I change. You know how people change? At Jefferson, everyone got reduced in the ER up to 160 pounds. We used to put the rotarest bed in reverse Trendelenburg and tie the ankles down. And we wrote a paper on why you can't use titanium pins on the tongs because titanium bends at 80 pounds. We wrote these papers from failing, from basically scalping people. We scalped people because pins would go. So if I didn't know what your exam is, I would do neurophysiological monitoring, get the guys come in, to get an MRI scan, and if it showed that it's complete on MEPs, I would go. I don't know if I wouldn't leave that like that because this is bilateral facet dislocation, spinal cord. I would assume he's complete, but I can get the information from an MEP. So that's how I've seen that before. That's how I manage that. So now what I do? So I go to the OR. Yeah. So when Matt was a fellow 8 years ago, was that when the vacuum cleaners took over? Schroeder and Kepler. I call them the vacuum cleaners because. Okay, so the vacuum cleaners weren't in effect. Yeah, so we have pictures for each one of us. My picture is a tree without limbs because I'm like right to the OR. So I'm not an algorithm tree. My trees have no limbs on it. I go. Argh. Schroeder's picture is a vacuum cleaner because he was so aggressive. Like I'd be on call. We've got this burst fracture. I go, put it on tomorrow morning. It would be like 2:00 in the morning, a phone call. I'd come in 5. The patient's discharged. He's been operated on. I go, the vacuum cleaner got here before I did. So the younger guys don't do the reductions anymore. Like Kotler told me to do the reductions. I'd be like, okay, I'd get a book, I'd write a paper, I'd sit in, and resident would put weights on it every 10 minutes. That's what I would do. The younger guys they don't do any reductions anymore. Isn't that funny? There's no reductions anymore. They will get an MRI and they go to the operating room. That's what everyone's doing nowadays. No one's doing reduction that I know of. Because I always ask, I go, I don't take spinal trauma anymore. I don't do it anymore because the vacuum cleaners took over. Like they would literally, I was on call like 12 nights a month and Schroeder would be like, can I have your call? I go, what are you insane? Of course you can. I'd be like, that's an IQ test. So the younger surgeons are very aggressive. I go, yeah, you take my call. It's perfect. And I always say, do you give steroids? No, a lot of them don't give it. I go, what do you do with dislocations? He goes, oh, we get an MRI first. I go, really? So things have changed.
So neuro intact, go right to the OR.
Well, if I feel it's going to slip, I mean, let me tell you how you get sued. Neuro intact, and then he slips, you're done. And let me tell you what people do in the hospital. They sun down, they get up, and they move around. Unless you're tying that patient down, I'd fix that patient. If bilateral facet dislocation, it's like an occipital cervical dissociation. Very careful. Take them to the operating room, fix it. We've had people who have lost function who have waited to the next morning. And the typical thing is this. They got up. They sat up in their bed. They're done. So you got to be careful. The younger guys do. I would always reduce them down unless they're not awake, not examinable, or head trauma. Because you can't get an accurate exam. So that it's MEPs and operating room. MRI, MEPs, operating room. Motor evoked potentials. And and I'm not against it either. Kotler would kill Steve and I if we did it that way. Kotler would fire us. If we didn't reduce them in the emergency room, you'd be fired at Jefferson. And then I became an advocate for that on the lecture trail. And then I haven't treated spinal trauma. I treat cold spinal trauma, but I haven't treated ever since the vacuum cleaners got the new engine on their motor, because they're refining the vacuum cleaners every year. My guys are aggressive. Don't ever walk into my emergency room. Yeah, we have so many. Yeah. We cursed.
Have to find out their preferred phone. Dr. Kirschbaum writing it.
Well, so the standard of care is you could do either one. There's no standard of care. So this is what I would do. If I don't do spinal cord injury that often, I'm getting an MRI first. You would never hear me say that 10 years ago. I would always be very aggressive, but if I don't do it that often, I remember when I did my fellowship at San Diego, Steve Garfin was supposed to be the best fellowship in the country in 1993. Now it's off the map. But back then it was like the best fellowship. I go out there, I'm like, I have post-traumatic stress syndrome from Jefferson, where it's like every night you don't go to bed with spinal cord trauma. I never came in once at all the entire year. And I never saw it. I never saw spine trauma the entire year. I was a fellow for a year there. We didn't, because it was like the way things have evolved now, where people would go to different community hospitals, the doctors would take care of them there. It wasn't busy. And he wasn't busy. It was a great fellowship because I played golf every day at Torrey Pines, because at 4:30, if you're a resident of San Diego, it was $4 to play if you're a resident. And I still have my card. So now it costs me $20 to play Torrey Pines after 4 o'clock. It's phenomenal. And I played so much golf when I was a fellow. And then the trauma emotional began again when I went back to Jefferson. I was like, oh my God. And it just was crazy. Guys, it was a lot of fun today. So thank you very much for your attention. I appreciate it.